the right set of skills to be able to do that.
We were able to open up the parliament to the public, and we have had an annual parliamentary week.
There have also been outreach programs like the reforestation in Moroto and other areas. The construction of the new parliamentary chamber was launched in July 2017.
Parliament lost a total of 35 working hours in terms of plenary sitting.
As the sun sets on the 10th Parliament, there will be memories of the great days, debates, events and achievements.
Brought to you by
Your Health Chart is brought to you by National Medical Stores, who are mandated to procure, store, distribute essential medicines and medical supplies to all public health facilities in the country.
A very good evening to you. I'm Sophia Matovu, sitting in for Dr. Henry Dungu. It's You Health Chat, proudly sponsored by National Medical Stores. Now, today we are going to talk about community involvement in the TB response program. One time, that was in the month of March, we did talk about, as we were getting closer to International TB Day, we did talk about how scary it is, because the rate at which TB has gone high is really very alarming. You'll find that the cases are actually more than HIV/AIDS in Uganda. Now, this program is under the Ministry of Health, and here with me in studio to shed more light about what it is and how or why they have opted to get community involved. Right next to me is Muzamiru Bamulova, a community systems technical advisor. Good evening to you.
Good evening.
And then right next to him is Dr. Aldo Brewer, who is a TB case finding officer. Good evening, Doctor.
Good evening.
Now, I beg, because we have talked about TB several times in this studio, for us to just have a mini recap, not necessarily what is TB, but I would like clarity on, or for you to share with the person watching you right now, how serious is TB in Uganda right now as we speak? Okay, Dr. Aldo.
Yes, thank you, moderator. Tuberculosis is a major public health problem in Uganda, and we actually lose about 40 patients due to tuberculosis every day, if you go by the statistics reported to the national program. We expect in a year, based on our prevalence of tuberculosis, about 85,000 TB patients every year. Yeah, so the number is quite significant. Looking at based on our population, it is quite significant.
Okay,
Yes.
Okay, you're saying the number is quite significant. Now, these statistics and in terms of population, is it countrywide or does it go by regions? Are there any specific regions that are more affected than others, or we say it's countrywide?
Yes, we actually find tuberculosis patients in every part of the country. There are some regions where we have observed the higher numbers being reported. This could be partly because they are finding the patients, while other regions which are not reporting adequately probably are missing on finding the cases. Basing on our data, there are some regions that report quite high number of patients. For example, we have Karamoja region, we have Lango sub-region, Acholi sub-region, and Northwest, that's West Nile region. They report quite high numbers of patients every year. Yes.
Okay, Mr. Mzamir, of course, I know you're also more in the community.
Yes.
Based on what he has said, why is it that those specific regions will have high cases? Because like if you look at a place or a case, say, of malaria, we all know quite for sure that there are certain areas which will be more highly affected, and the reasons we know. Are there any specific reasons from your findings as to why these particular areas would have higher rates vis-a-vis some other areas?
Thank you, moderator. Actually, to pick up from where Dr. Aldo stopped, what we should actually give to our viewers is even as we see the high numbers of cases, there are also high numbers of deaths. But in this, you will see that of the so many cases that we have per year or per day, you would see that the majority of them are men. I'm trying to drive to your point where we can see some specifics in regions where regions have higher numbers than the others. So one of the key issue is the behavior or the behavior patterns from those different localities. Men who are always going and sit, or those who are actually going into gathering places, let's say like betting, they are going for drinking, they are actually sharing one location, and you know the mode of spread is by presence of the infectious agent in the air. So whoever inhales the air which is contaminated by the infectious agent, then that person is actually at risk of developing the disease. Then too is the mode of management of the clients. Actually, I can call them patients. These patients are actually living in some locations, let me cite, let's say slums, where 4 or 5 live in one small room. So our settlement pattern, our housing pattern is a contributing factor in some of the locations. Let me cite, you would see that most of the cases which are coming from urban areas are coming from slum areas. Why? More than 5 or 6 or so many people are living in a small area, whereby it is a small car room, aeration is not good, lighting is not good, and we know the repercussions or the importance of having good lighting and ventilation in a room. It helps in killing the infectious agents and thereby reducing the chances of infection. So people who are living where they are highly crowded, they are actually at high risk of developing the disease if one of them is infected.
I understand.
Yes.
Okay, now as the Ministry of Health opted to develop this program, would I be right to say it was based on the high cases of TB countrywide, and you want to counter it? And then why do you choose to have community resource persons involved, as opposed to, if I have a problem, I can walk to the hospital? Why would you choose to get the community involved?
All right. So tuberculosis, there has been a national response to tuberculosis control under the National Tuberculosis and Leprosy Program. So there have been efforts to find the TB cases patients out there and put them on treatment, because that is the most effective way of control, through early identification of the tuberculosis patients and initiation on treatment, so that they do not further spread the disease to others in the community. Now, why this time around, why we're emphasizing on engaging the community is because viewers, you're all aware we are in a situation of COVID pandemic, which has affected almost most of the countries globally, and Uganda is not an exception. We have been we had registered significant progress in finding TB patients and putting them on treatment. However, during this 1 year or so, when COVID came in, struck in the country around March, you all know what happened in the measures to control the spread of, of COVID. there was the lockdown. And during this period, it was difficult for people to access services, health services, especially during that period between March up to May, June. And we noticed that our indicators for tuberculosis case detection had gone down. Actually, we noticed a drop of about 15 to 20% of the expected patients we expected to find. So this raised an alarm. We got concerned, because if people do not find them and they're out there in the community, just as my colleague mentioned, tuberculosis is an infectious agent, and it's acquired through breathing. As long as you breathe, you're at risk of getting TB if you get into close contact with somebody who has tuberculosis. So there has been this challenge of reduced notification, finding of tuberculosis patients, and the worry that they are spreading out in the community. So there have been measures. When the government lifted the lockdown, we put in efforts to try to reach out to the people with services so that we can find the TB patients and bring them to care. So it's through this community engagement that now we are going beyond the health facility, because we are aware that about a quarter of the people out there do not reach health facilities. So we wanted to make sure that we're able to reach out to them and get care. And the community resource persons at the entry point to go into the community.
Okay.
Yes.
Now, Mzamiru, the signs and symptoms are pretty much the same. The ones you talked about, COVID-19, likewise the ones for TB. How will you be able to make a clear, distinct factor between the two? I'd like to beg for the technical team to flash for us the signs and symptoms as you tell us about them. How, because I know they are pretty much almost similar.
Thank you. The signs are many, but as they are flashing them, one of them is prolonged coughing for more than a week. Actually, if you cough for more than a week, we advise that you visit the nearest health facility and you are thoroughly examined so that we can rule out what could be the probable cause of the cough. Then two is, in most cases, people do night sweating. You are in your bed. By the time you turn like this, you would actually think somebody has poured a jerry can of water onto your side, but it is basically a sign of TB developing or growing in you. On the other side, you would actually see yourself losing out your weight, having muscle wastage. You'll actually shrink, you grow thin, actually with no defined reasons why you are losing your weight. So if our viewers, you realize, you see your weight is continuously reducing, get to know that there is a problem which needs to be thoroughly examined, then we should be able to see what could be causing that. Any other thing is the element of chest pain. You will actually have unexplained chest pain. You've not carried any weight on your head, but you're actually finding the chest is actually as if it is loaded. So in such circumstances, you should actually visit a nearby facility to confirm. Actually, our being here is basically to make sure that people understand these signs and symptoms, but the key bottom line, for any time and moment you feel like your health status has changed from what has been the norm in your side, visit a health facility to rule out what could be the issue that is causing that. So lastly is the element of losing appetite. In most cases, when somebody has started to develop TB, he will actually lose appetite, and that is partly linked to the loss of the body weight, because if you are not eating, then certainly the body will not actually sustain or either maintain its original size. You will automatically have the muscle wastage, and you'll actually have to be like malnourished. Yes.
Okay, then we get to the point of where you said some of the reasons, like during the period of the COVID-19 pandemic,
Yes.
it was hard for people to move to the health facilities. What are the chances that people are not stigmatized? I mean, since the symptoms are almost the same, so do those for COVID, that people will not even want to associate with somebody right now once they realize that they have TB. Clearly, for them mentally, they will do their own diagnosis and say that this is COVID, but not TB.
Yes, thank you. That's why we want to make it clear to the public, to our viewers, that tuberculosis and COVID-19 present in a similar way. Even the mode of transmission is through air, breathing, and affects primarily the lungs, so it's similar. However, there's a distinction between the organisms, the germs that cause its disease. That's why we want to provide information to the public so that they are aware and they're able to seek services. The healthcare worker, when you feel unwell with some of what my colleague mentioned, either you have cough for more than 2 weeks, or persistent fever, excessive sweating, weight loss, loss of appetite, you should go to the nearest health care provider so that you can be investigated and examined for TB and receive treatment. So the healthcare workers really can distinguish between the two conditions. COVID-19 tends to happen quickly, while tuberculosis is more of a slow process. Yes, it progresses slowly, and most likely you have been unwell for some time before you can get concerned and seek services. But the public, all we want is for them to be aware that when you have any of these signs and symptoms, you should come to the health facility, and the healthcare providers will help you accordingly. So we should not feel stigmatized. Yeah, and the public should really be supportive of any member of the public in the community who has such signs and symptoms, should be able to seek care from the health facility.
Now, since you have, okay, please go ahead.
Actually, even to add on what he has said, there is no reason for why one should actually be stigmatized because of either the cough, either the other symptoms that you are developing. The beauty about some of these symptoms, they are actually showing that your body has a foreign substance in it. In this case, it is an infection. Most of these infections, or let's say like TB, it is a disease that you can treat and you actually completely heal. Therefore, people out there should actually not look at saying, now I'm going to be identified as a TB case. By mere being identified as a TB case, to me, it is a key indicator that you're actually now progressing to the point of healing, because they will be able to give you the right drug, the right medicine that should actually help you to heal very fast. So we better go to the facility early enough, they diagnose you and rule out either it is coughing because of malaria or coughing because of any other infection. This is coughing because of TB. It can be treated.
Then how about the fact that some still further get stigmatized because they believe the mere mention of saying somebody has TB, it's associated with HIV and AIDS?
These two at times move together. In most cases, patients of suffering from HIV, in most cases, they will actually also develop TB. Why? HIV, as you see it, it reduces your immunity in the body. As it reduces your immunity in the body, by mere exposure to the virus that is actually the bacteria, which is actually causing TB, because your system is already weak, there are higher chances that it will be able to take up you and you actually develop the disease. It's like if I'm actually fighting you and you are really weak, I have the ability to put you down. Therefore, there is always a linkage between HIV and TB because they always find individuals whose immunity system is already lowered. So there are higher chances of the disease to progress very fast.
Okay, yes, Dr. Aldo?
Yes, just want to add that it's not necessarily that when you have TB you have HIV, or when you have HIV you get TB.
Yes.
From our data at the national level, less than half of the TB patients are co-infected with HIV. Yes, actually it's about 40%. 4 out of 10 TB patients have HIV co-infection. So the majority actually do not have HIV. So the public should know that you can get TB even when you have no HIV. Yes, the risk factors, as he mentioned, close contact with somebody who has TB, like within the household, you're breathing almost the same air is circulating around. Maybe your immunity can reduce for other reasons. It could be malnutrition, it could be diabetes, chronic infection like diabetes, or you're on treatment for maybe cancer. Those other conditions which lower your immunity can actually predispose it to tuberculosis disease. Yes, so when you have signs and symptoms of TB, do not fear that you might also have HIV.
Unless
we
it's
encourage you go
ruled
to
out.
the health facility. The health workers will help to screen you and they'll offer you the necessary tests. Yes.
Okay, now I would like us to get into the bit of like this wonderful program that we're talking about, the one which is designed to involve the community in the response, because I believe if the community is able to respond very fast, then we'll be able to hit the target of ending TB as is planned. What is the program like? How is it designed in such a unique way? How do you intend, like especially now during this new normal era, to reach out to the community that will be able to support the healthcare systems?
Thank you. The design of this intervention, where we want to get our patients who probably missed treatment, who probably missed care because of either the restrictions in terms of movement, in terms of accessibility to other locations, is it is going to be a community-based intervention. As you've earlier mentioned, that we are even engaging community influencers, community actors. So we are going to go to, the design is actually looking at 50 districts. We identify districts which are having high cases, and therefore in our design we started with a national level orientation to get people who should be able to go and orient the district teams. If I say the district teams, I'm basically looking at the office of the district health officer together with the district TB and the process persons or supervisors, the focal persons for lab within the districts, so that we build a mass of individuals who are actually now focused specifically with the key element of finding the missed TB cases. So we are actually having now a jointed effort between the national level, the district level, the health facility level. We are now moving to the community. The one single community called X is where we are going to look for our clients. In this case, they are the missed TB clients. So we are going to engage village health team members. These are our level 1 facility soldiers. They have the art, they have the knowledge, they have the skill as far as primary level science in health service delivery is concerned. So we built the capacity of the VHTs, the village health team members, to be able to screen people in their locations. I, like let's say Mzamil, I present myself, or the VHT comes either to my home, then he actually introduces himself, then we should be able to, he asks for the signs and symptoms. If I have any of those that were earlier mentioned when we were actually discussing here, then one, he either picks the sample that is the cough from me, and it is taken for testing, or he or she refers me to a nearby facility for further investigation. That is one. Then two is we are going to do a modified system of community mobilization and sensitization. We are not going to have large gatherings, but they are going to have door-to-door visitations as they mobilize and sensitize people, so they should actually know the signs and symptoms. They should know when they should go to the facility, specifically to look at TB interventions, so that we raise their level of awareness, so that they should be able, even within their own homes, to say, no, Muzamil, you've coughed for more than 2 weeks. We were told if you cough for more than 2 weeks, you are a suspect of TB. Can we go to the facility? We were told the services are there. So that is actually what we are going to do in a modified version. And we are going to do this activity intensively for 4 days. Actually, as we are actually speaking now, this activity is ongoing within the 50 districts where we are doing the interventions.
Okay, now when you talk about it, because there are some of those cases when you say the missing.
Yes.
Are we talking about those where you possibly suspect, or are we talking about some of those who have defaulted, where somebody has been on treatment, but due to the fact that they could not reach the health facility to be able to get their medication, somewhere along the way they dropped off treatment? What is it, a combination of both, or you're looking out for one specific category of persons? Because somebody might cough, and these days we are experts at going and getting off-the-counter drugs without a question or a doubt. Please help clarify on that.
The genesis of this activity, where we are saying community involvement, first of all, what we need to understand between we here and the viewers out there, that this disease does not stay up there in the air. It is within us, and we are the people who make what we call the community. So the genesis is looking at a scenario during the time when COVID was declared in Uganda. As a measure of controlling the spread of COVID, there were restrictions which were placed in place. So because of these restrictions, some people were unable to move from one location to another. So in this essence, we had people who had been enrolled into care for TB. There were known TB cases in our facilities. But because of the restrictions on movement, some of them chose not even to come back to the facilities. They were like, if I go to the facility and maybe curfew finds me, I will have no explanations. So these are the people we're actually looking for. Those who have actually defaulted from completing treatment. Because what viewers should know, that one TB case can infect more than between 10 to 15 other members in a year. So we don't want those who have probably defaulted to remain in the community. We want actually now to go and say, Muzamil was one of our clients. He was coming from a village called Aldo. So the VHTs who are actually in charge of the village called Aldo are going to look for Muzamil who defaulted, and they mobilize him to come back for care. But at the same time, because Muzamil has been out there and is already with his disease, we know the people who have been around him, some of them probably have now contracted the disease. So we are even going to do a contact tracing for those clients, so that even those will be actually screened, examined, tested, and confirm whether they have actually acquired the disease. So if they have not acquired the disease, we will actually move into another level if they are either children that have been in contacts, to give them what we call a presumptive test, a presumptive treatment, so that it is to prevent them from getting the disease. My colleague can add.
But 4 days looks like a short period of time.
Yes.
Based in those areas. How many VHTs are we looking at to be able to help you accomplish and achieve that task?
Yeah,
per region.
Before I answer, you just wanted to pick on from what Muzamil he has talked about, following those who have interrupted treatment, contact investigation, in addition to case finding within the communities. There are people we know who actually do not go to health facilities. They probably, when they feel unwell, they go to other providers, were not the formal.
And the hub.
Yes, I didn't to mention. Yes, the non-formal services. So we are designed the intervention such that we're able to reach out to the different sections. So one of the approaches is by looking at our records at the health facility to see where most of the patients are coming from, what we call hotspot mapping, so that we identify areas where there are concentration of clients, where there are TB clients, where they're coming from, because we think they could be transmitting within that area. So in such locations, we organize community sensitization or dialogues, but in such a way that we don't bring people gathering together. We reach out to them and then do door-to-door within that specific area. Try to minimize big gatherings. Yes. So through that approach, we're able to reach out to a number of people, probably who will not come to the health facility, and yet they could be having tuberculosis. So that's in addition to what he has mentioned. So to come back to, it's true, the activity, the actual community activity is for 4 days. Okay, let's say for a week, because we started planning from Monday, and then the teams went out from Tuesday, and they are still going on. This is more of like a pilot. We are starting something, and then learning from it, and then we're able to scale up to more districts. So it's time bound. Is we want to demonstrate that through this intervention we can actually impact, you can show results. So we hope that through this process we're able to document the lessons, and then we'll plan in a bigger scale. But for your information and for our viewers, in this short time we have reached out quite a number of communities. In each health, the design says that in each health facility we have a team of healthcare workers and village health teams. Actually, for each health facility we have a team of about 17 people. So we have a mix of healthcare workers, community village healthcare workers, and community local leaders. So they form that team who move out, and you know, most of our health facilities that offer TB services from around health center 3 and above, so they are almost at the level of a sub-county. But then through these 17 member team, they're able to spread out and reach out to the different parishes and villages. So, and it's not just going anyhow, but it's targeted, because remember we said we first did hotspot mapping to identify where most of the patients are coming from. And also we identify the patient and then go to the home. So through contact investigation, we are able to reach to the home and screen the household members. So it is a bit targeted, although the time is short, but we are trying to demonstrate results, and also learn from it before we go on a large scale.
Now, when you do your findings in this particular program, I'm the VHT, yeah? I have come to your home, I have identified that you defaulted, possibly. And if you're still in a good condition, now what do I do? Are the VHTs supposed to refer this person back to the hospital? Or if the person is bedridden and unwell, they'll be able to help them deliver the drugs to them, to be able to put them on maybe another regimen to get onto treatment. How does the program continue?
The continuity of this program is designed in a manner that it is supposed to be a user-friendly service delivery mode. As it has been mentioned, that we are first of all using our information within the facilities to know that a person X has not come back for maybe 2 or 3 months to get the drugs. Before they even come to your home, there are details at the facility. So they are going to give you a call and say, let's say you are Esther. They say, Esther, I'm so and so, a health worker from a facility X. We wanted actually to follow up with you on an issue of the TB treatment. where can I find you? We are not actually going to hunt for people like we are in a bush with dogs and pangas. No, this is a service delivery mechanism which is going to be actually almost client-led.
Okay.
It is the patient who is out there who will actually even tell them, no, actually, if you want to talk to me further, I'm even now currently seated, if the patient is in Kampala, he can even tell you, no, I'm actually seated here at maybe Garden City, come. So that our health workers, our VHTs will go and sit with the patient and find out what were the reasons that made you not come. Then it's like, no, maybe one of them, the distance is so high. So they can at that point agree whether we can now deliver the drugs to you, or we can find a nearby location and say, no, if you bring the drugs, since I stay in Kawempe and initially I got them from Kirudu, maybe be putting them in Kawempe Health Center, 2 or 3. That means we will actually want to find a mechanism that is easy and friendly to them to continue with the treatment. So that we remove those barriers of long distances. I don't have money for transport. Maybe I have other obligations at the family. So we want, this campaign is strategically to find local solutions that can motivate people who have TB to access services for TB.
Fantastic.
Yes.
Then how are you going to deal, because I mean it's draining, loss of appetite, you've lost weight, now the drugs can be delivered to you, but then you can't afford to have food. How do you intend to manage how are you planning to manage some of those situations? Because I'm made to understand people also, you know, sometimes will gain appetite and they need that food to take the drugs. One of the reasons as to why some of them default is they'll tell you, I don't have food, and the medication is very strong. How is the program going to cater for that?
That is a good question on how can the program cater for this. First of all, by mere presence of one TB case in one family, it has a number of bad things that can happen in that family. One is because this person is sick, you'll lose your time to look after this person. Two, because he's sick, he is unable to go and work, neither to go to the garden, but even the other family members can't do anything. So the design in this format is we actually saying we need a community, we need actually to have total involvement and engagement of the communities in a way of supporting the TB patients. One, to be able to take the drugs. Two, for any other social issue that needs to be solved. It should be now a community issue, not an individual issue. Either a family issue, so we call for family support and community support. If I'm actually living in a village where I'm the only one probably with either a very good bicycle, if this person needed to go to the facility and he either probably approached me, I'm supposed to refill my drugs on a day X, but it seems I don't have transport to go there. It would be very okay for any other community member, you offer the bicycle, you offer any other support, so that we can support these clients to go and complete treatment. Because the repercussions of one sick person are beyond the help of a bicycle for this person to go there, are beyond the help of saying, oh, today I've actually offered you a bunch of banana, you use in your family. So we are calling for total community support to our TB clients, as even the government does its part of providing the consumables. Yes.
Okay, that's a good one and quite interesting. I do really personally see that it's a mode I really see now that is kind of like workable. Now that brings to what are the benefits? Because, you know, also some people have a locked mindset. Is there a situation whereby if somebody possibly defaults because they were feeling better, and then what are the benefits of them adhering to taking the treatment? You know, there are certain times some people feel like it is me who is sick, but I feel like I need to be convinced on why I should adhere to taking my medication. Maybe on a medical perspective, Dr. Brewer, you can tell us a bit about that, because it is strange. Somebody will feel better. We have the tendency. You feel better, then if it's you default. I mean, why should I complete the dose?
Yes, thank you, moderator. And the reason why patients should be started on treatment early is because TB is curable. When
And
you take your
treatment is
medication,
free.
well, yes, it is free of charge and it is curable. And TB kills. So we don't want to lose somebody because he doesn't take his medication. Since it's curable, we really want to pass this information that when you have TB, do not fear, you can get cured if you take the medication. So the benefit of treatment, of course, the first is that you didn't want the person to spread this disease to other people. So when you identified with TB and started on treatment, normally along the course of treatment, the germs clear off. Doesn't mean that you've now completely recovered from the disease, because the treatment normally takes for a duration of 6 months. But you must take your medication daily for this period of time. If you do not take your medication properly, the germs can get stronger, what you call, they can develop resistance. And you get another form of TB which is undesirable, called the drug-resistant TB,
yes.
which is more difficult to treat, more costly, and takes a longer period. Most times we treat for 1 to 2 years, depending on what treatment regimen you are on. So we would not want to go to that line. So we want any person who is suffering from tuberculosis, once he's started on treatment, should follow the advice of the healthcare workers and adhere to the medication for that period. There are also other complications of not completing treatment. You can get problems. I told you that the disease primarily affects the lungs. You can get complications in the lungs, which will affect your day-to-day activities, and also can also lead to loss of life. Those we don't want to reach that extent. And then there is the risk, of course, of relapse, the TB coming back. So you can think you have now recovered, you're
And
okay,
then it comes back.
but afterwards it comes back. So, and my colleague Muzami will talk about loss of productive time. If you're always sick, you will not be able to work. And also the people looking after you, the caretakers, also there's loss of time and the resources, income. So it's the benefit really outweighs the of treatment, really outweighs ignoring treatment.
But does this beautiful program have a scenario follow-up? Because given that it's being started as a pilot, somebody will get onto the VHT will come to you once. Are they going to continue still to follow up? Because if you have to take a treatment for 6 months, will they follow up and ensure that you do your whole range of treatment for the 6 months? Or it is just at the start, then after this dialogue, you should be able to motivate yourself to keep going to the health facility to pick up your medication? What is it like, Muzamiro?
You know, we've tried to build a system that goes up to the community. By mere hearing the title Village Health Team Member or VHT, these individuals actually stay in the communities. And by virtue of their orientation, they are part of the health system. One of their roles is to do community mobilization and sensitization for the uptake of health services. Therefore, it is going to remain part of us with the VHTs to remain continuously following up these people that we've actually identified during this period to continue with the treatment. Then too, when we enroll these individuals onto care, we actually even give them a leeway to say, no, I think Aldo can be helping me as I'm taking my drugs. So they even have treatment supporters who actually keep on supporting them, either socially, either morally, to say, no, actually I can see you now, you're even improving. Continue swallowing the drugs. So even in the format of taking the drugs, we actually have a connotation of saying it should be directly observed treatment. The person who is actually taking the drugs, there should be some other person who is actually observing and giving him support to continue taking the drugs. The months are reducing, as you've said, 6 months, it may look so big, but of course, when you look at what you are saving, specifically your life, 6 months is not so bad. So these are the treatment supporters who are around you, the community linkage facilitators. They are there to support the team, even the person who is a patient, to continuously take the medication.
Oh, that's interesting. Are there any other interventions besides that to help that you have, or that the program has, to put in place to control the spread of TB? Because yes, you're treating these other people. Then of course, even like I saw it during COVID, during contact tracing, nobody would like to be tagged along. Likewise here, as you're doing your contact tracing, some of the family members might outrightly deny, or might also decide to run away, or later might choose to stay there. But you know, as I am there, if I'm not showing the signs and symptoms, and maybe later as this person cures, then yours also progresses or something, that kind of scenario, how are we planning to manage that? Dr. Aldo?
Yes, thank you, moderator. So while we go out through our community teams to the households to trace contacts probably of TB patients, it's not done once. We actually do periodic contact tracing. So first of all, the VHT is a member of the community. They are living with the people in the same community.
So it will be easy for them to identify.
Yes, they can identify when you. First of all, one of the important things is the information that we are giving out. Through these community dialogues and sensitization, we're able to give out information. We're also providing education materials, information education materials to tell people about TB and how to recognize symptoms, so that people know that I have a problem and they're able to seek care. So the first time we can do screen the household, but after another period, no, we recommend after every 3 months you can do another follow-up. But also, while we screen, we're also passing other messages of prevention. So prevention takes various modes. One of them, of course, is by tracing the contacts and making sure that they are identified early and start on treatment so that they don't further transmit. That's one. But also, there's the preventive method of within the household and the community. Remember, tuberculosis is an infectious disease. That's why we encourage that we observe the preventive measures, putting on a mask, especially if we have a TB patient in the household. And now for COVID-19, so the two really serving the purpose for both. By enforcing, we've been actually emphasizing use of face masks for some time, but people are not appreciated until COVID-19 came up. So we are reinforcing that message that if you have maybe respiratory symptoms of cough, sneezing, you should always put on a mask to prevent exposure of other people. So that's one of the effective measures of prevention. But also hygiene, sputum hygiene, in terms of if you're a TB patient in the household, how you should manage the excretions when you cough, how you should manage them, not to spit anyhow. All those are preventive measures. In a way, they protect the household members, but also it's information to the public so that they do not stigmatize, because stigma is the biggest problem in the community. When people because of stigma, they will hide. They will not come out openly to seek services for various reasons. And sometimes the stigma is because of lack of information. So it's through this program that we're able to take information right to the people and inform them so that they're able to take informed decision to seek care when they feel unwell.
Okay. Now, with this program that you have started, have you gotten any feedback so far for the days that the VHTs have started on this? Have you been able to identify some missing cases?
Yeah, actually, from the start of the intervention, that was around Tuesday this week, the VHTs and the health workers, earlier mentioned, from the different locations are in the communities. We have actually got some feedbacks in terms of those that have been actually found in the communities. We've even gone ahead that for me to get a feedback, I must not be in probably Kwen. We have come up with an online reporting system. There are actually, whoever that is an index case, whose contacts are traced, and even those who defaulted, they have been traced. They are actually feeding directly into an online system, and we are able to see some of this information. Of course, from the look of things and what has been so far seen by the system and what is reported by the district teams, the activity is progressing on well, and we'll be able to hit relatively above 70% of our target.
Oh, wow,
Yes.
that's nice. Okay, well, just a few minutes for us to wind up. I'd like to start firstly with Dr. Aldo. What is your final message to the person watching you right now?
Yes, to the public, I want to reassure the public that tuberculosis is a curable disease, but you need to be aware of the signs and symptoms that maybe you're unwell when you have cough, which is persisted for more than 2 weeks, or you have persistent fever, loss of appetite, you could be having tuberculosis. Or you need to be investigated for TB. So I encourage the public, I urge the public to seek services. We offer TB services in almost all the health facilities from the level of health center 3 and above. So the services are available. Screening can even be offered at the lower level facilities, including the private care providers can offer screening services, and then they link you to for diagnosis and treatment. So the treatment is available, it's free of charge, and you lead a normal life. So I encourage you to seek services and lead a normal life. Thank you.
Okay, Ms. Emery, your winding up remarks?
Yeah, thank you. Thank you to our viewers. It has been nice to interact with you, have these discussions. But as how my colleague has put it, we need to look at life as one of the things that we need to value most. Wherever you see anything touching your life, first give it priority before you do any other thing. TB is curable, the drugs are available, the health workers are there, and any other person, either within the community, is there to support you. So whoever sees any symptoms or signs as those we've mentioned, just visit the health facility for further guidance and management. Thank you.
Okay, thank you so much, gentlemen, for taking the evening off to be able to share this very important information with us. For you who's been watching You Health Chat, thank you so much. I don't think I need to ad-lib and add anything more. It's all been said. The government of Uganda has made it possible for TB treatment for years, has been for free. Please adhere to your medication because you do not want a relapse or you do not want to have drug-resistant TB. That is all we had for you on You Health Chat tonight. Catch you next week, same time. Keep watching UBC for the 10 o'clock news. Will be coming your way shortly with a beautiful lady, Rhoda Ngonzi, and Elizabeth or the sign language. Good night from me and the team.
Thank you.
Chart is brought to you by National Medical Stores, award mandated to procure, store, distribute essential medicines and medical supplies to all public health facilities in the country.